Good evening. I hope that you are all fine and welcome to the ultrasound course. My name is Sami Slimani. I'm a rheumatologist from Batna, Eastern Algeria, and it's my pleasure to make a summary of the importance of tenosynovitis in rheumatic diseases, especially in ultrasound. I do not have disclosures with regard to this presentation. So this is the agenda of my presentation. First of all, I'm going to define tenosynovitis, then talk about the standardized scanning in ultrasound to check for tenosynovitis. I will illustrate it with some examples, and by the end, I'm going to try to answer why we should look for tenosynovitis when performing an ultrasound scan. So the first item is to define tenosynovitis. I have the definition of Omeract from 2013, which defines tenosynovitis as being the presence of anechoic or hypoechoic thickened tissue surrounding the tendon. It means tendon sheath, which should be seen in two perpendicular planes and that might exhibit Doppler signal or not. We have an illustration of this definition below. We have on the left a normal extensor carpi ulnaris tendon with its fibrillar linear normal aspect. And on the right, you have the tendon in the middle, but it is surrounded by some abnormal material. We have hypoechoic and anechoic material on the top and on the bottom of the tendon. And we have some Doppler spots. So this is the classical definition of tenosynovitis of the extensor carpi ulnaris. A normal tendon could be surrounded by a tendon sheath, which is composed of synovial cells, but we could not, at a normal situation, we can't visualize it on ultrasound because it's so thin and no virtual layer should exist between the tendon and the surrounding structures. Tenosynovitis doesn't deal with all tendons in the body because not all the tendons are covered with synovial sheaths, but major tenosynovitis is looked for on the hands and the feet because 80% of tendons that possess a tendon sheath are located on hands or on feet. On other tendons like proximal tendons and very big tendons like Achilles tendon do not possess tendon sheaths, and pathology dealing with these tendons is not tenosynovitis. So we can have tendonitis, which is a thickening with abnormal qualitative and quantitative material inside of the tendon, or we can have enthesitis, which is the abnormalities that we find on the junction between tendon and bone. A standard scan of tendons requires some elements. We should have a good ultrasound machine with a good Doppler mode because Doppler is very important here in detecting inflammation. We need a probe which has a linear array and a minimum frequency of 10 megahertz. And we need a person that is trained with some experience in scanning normal subjects and in scanning some pathological patients. Here are some tips in performing ultrasound examinations of the tendon. First, we have to perform bilateral comparative examination because we can have false positive or sometimes false negative patients. So performing a comparative examination on the other side can alleviate some confusion in this case. We should not compress the probe when putting it on the skin because compressing it will decrease Doppler signal and thus decrease the quantity of information that we can get to quantify inflammation in some pathologies. We have to apply much gel, not like in this illustration, but we have to apply much gel in order to avoid to compress our probe. We have to avoid anisotropy, which is a common pitfall when we perform ultrasound for the tendons. We can avoid this pitfall by applying our probe in a perpendicular way to the skin in order to have the typical fibrillar and hyperechoic aspect in the tendons and avoid the hypoechoic aspect that can be misinterpreted as a pathological sign. And finally, we have to perform dynamic examination because ultrasound is the only imaging that offers this advantage of performing dynamic examination, and some small abnormalities like fluid or small tears can be only seen when we perform dynamic examination. Here are some of my personal examples of tenosynovitis seen on my patients. On the hands, we have here an example of a tenosynovitis with no Doppler signal seen on the extensor tendons of the hands on the third compartment in a patient who had trauma and who had still had pain on his on the dorsal side of his hands. We have the presence of a mixed hypo and anechoic material under and on the top of the tendon sheath. When we have abnormalities, we have to confirm it on the perpendicular way, on the transverse way, because we can have some false negative, false positive aspects. In the middle, you have infectious tenosynovitis of flexor tendon, seen on a patient who had Staphylococcus aureus infection. So we can see the tendon, which is normal in the middle, surrounded by abnormal material composed of anechoic and hypoechoic material and Doppler spots, which witness the importance of inflammation in this tenosynovitis. And below you have tenosynovitis of the extensor tendons in an inflammatory condition in a peripheral psoriatic arthritis. Here we can see hypoechoic material on the surrounding the tendon, which corresponds to synovial hypertrophy. We have some Doppler spots inside of the tendon and on the tenosynovitis, on the inflammation below. Now we have some rheumatoid arthritis patients. On the left, you have this in the same patient, tenosynovitis of the fourth compartment seen on a longitudinal scan and on a transverse scan. Notice that we have a kind of separation of the fourth compartment tendons, which normally shouldn't exist. And this separation is due to the presence of inflammation between the tendons. On the right, we have also in rheumatoid arthritis patients here active tenosynovitis on the fifth compartment of the hand, and on the bottom you have tenosynovitis of the extensor carpi ulnaris, which is very frequent in early rheumatoid arthritis. On the feet, we can have equal abnormalities with the same frequency, especially on the tibialis posterior tendon, which is one of the earliest affected tendons in rheumatoid arthritis and in spondyloarthropathy. We have a very active tenosynovitis on the transverse and longitudinal views with the Doppler signals inside of the tendon and surrounding the tendon. And here we have tenosynovitis with a lesser activity on the tibialis anterior with very few spots as compared with the image below. We can say if yes or no we have tenosynovitis, but also ultrasound informs us on the importance of of tenosynovitis. Omeract defined a kind of grading in order to quantify the importance of tenosynovitis, both on grayscale and on Doppler. On grayscale, we have a classification that goes from 0 to 3, with 0 as being a normal tendon on transverse and longitudinal sides with no inflammation. A grade 1 corresponds to the presence of a a minimal amount of fluid or of synovial hypertrophy. Grade 2 corresponds to a moderate amount of inflammation, and grade 3 to a very important amount of inflammation. This is very useful when we follow a patient in order to have an appreciation in time of the importance of tenosynovitis. But also it is important in research, in clinical research, in order to better appreciate with numbers the importance of inflammation and response to treatment. We have the same classification with the same semi-quantitative score when we are dealing with Doppler mode. So we have grade 0 is when we have no Doppler spots inside of the tendon sheath. Grade 1 when we have only 1 or 2 or a maximum of 3 spots on the tendon sheath. Grade 2 for Doppler is when we have many tendon spots, but not exceeding half of the surface of the tendon sheath. And grade 3 is when we have too many Doppler spots that cover more than half of the surface of the tendon sheath. So why looking for tenosynovitis? This looking for tenosynovitis is very important because it has it offers many advantages in the diagnosis, in establishing prognosis, and in treatment follow-up, especially in rheumatoid arthritis. Most of the publications dealing with tenosynovitis were with rheumatoid arthritis. There is very few publications with other diseases. So here we have a publication dealing with MRI, but the same thing could be said when dealing with ultrasound. The authors tried to answer whether the adding of a tenosynovitis score can help in improving the very well-known ACR-EULAR criteria for diagnosis of rheumatoid arthritis. They have taken patients for whom they have applied the ACR-EULAR criteria, and they have performed scoring, semi-quantitative scoring for tenosynovitis, and tried to find, with a gold standard as being the judgment of the clinician, and they tried to see if adding a tenosynovitis score can help in improving sensitivity or specificity of the ACR-EULAR criteria. They have explored both hands in every patient and looked for synovitis as well as for tenosynovitis in every hand of the patient at inclusion. So here is the main result, is that when applying only ACR-EULAR criteria for rheumatoid arthritis and comparing it to the gold standard, which was the judgment of the expert rheumatologists, they found that the specificity of this criteria was of 100% and the sensitivity was low of 52%. But adding the presence of at least one tenosynovitis on the hands, the sensitivity was still remained very high of 100%, and sensitivity jumped from 52 to 76%, which is very good. So authors concluded that adding at least the presence of one tenosynovitis of the hands in early rheumatoid arthritis may improve sensitivity without sacrificing specificity for the diagnosis of rheumatoid arthritis. Another work that included more than 100 patients and included undifferentiated arthritis for less than 3 months, for which the authors performed US of joints and tendons of the different extremities and applied an OMERACT scoring of tendons and for joints. And they have seen again patients 18 months later with a definite diagnosis. So among the 107 patients, 46 only were diagnosed with as having certainly rheumatoid arthritis. 17 patients were diagnosed with other diagnoses like spondyloarthropathy and crystal diseases, and 44 patients were healed and didn't present anymore any kind of joint complaints. And they have tried to find out which kind of ultrasound signs that can predict among these 107 patients the evolution to an established rheumatoid arthritis. They have explored flexor tendons and found that the presence of a grayscale or a PD flexor hands tenosynovitis increased by 5 the likelihood of getting rheumatoid arthritis at 18 months. And the same thing was found when exploring extensor tendons, but not all extensor tendons, it was only with extensor carpi ulnaris, for which either grayscale or PD signals were predictive at 6 times, 6 folds the prediction, the power of prediction of becoming rheumatoid, an established rheumatoid arthritis. The authors concluded that we have to check for the existence of tenosynovitis of the flexor tendons and extensor carpi ulnaris in every patient with inflammatory arthralgia that can evolve to rheumatoid arthritis in order to get a prognostic score, and having a higher prognostic score should require more attention towards the use of aggressive treatments like DMARDs and combination therapy. Tenosynovitis also has another interest in predicting structural progression in established rheumatoid arthritis. Here is a MRI and ultrasound study that included 60 early rheumatoid arthritis patients of 1 year of evolution. All patients benefited from X-rays, MRI, and ultrasound at inclusion at 12 months and at 36 months. And authors tried to search for prognostic factors at inclusion that can predict the progression to a more erosive disease at 3 years. And one of the most predictive, strong predictive factors was the presence of tenosynovitis on extensor carpi ulnaris on both hands, even found on MRI with an odds ratio of 7, or on ultrasound as well with the same score with an odds ratio superior to 7. The authors concluded that when performing imaging in early rheumatoid arthritis, we have to check for the existence of tenosynovitis of extensor tendons, especially ECU, to have an idea about the further evolution of the rheumatoid arthritis patient. So tenosynovitis is important in diagnosis, in prognosis, but also it is as sensitive to change as synovitis. Here is a Spanish study by Naredo, who tried to study this kinetics of the evolution of tenosynovitis with time under effective treatments. They have included 57 patients and evaluated them at a baseline, at 1 month and 6 months, performing clinical and ultrasound examinations and creating a composite score for tenosynovitis. And they found that there was a very strong correlation between clinical scores, the most used clinical scores that are CDAI, SDAI, and DAS28 at inclusion. A good correlation between clinical composite scores and ultrasound scores of tenosynovitis, either grayscale or PD scores at inclusion, but also there was a very good correlation as well at V2 at 6 months. So tenosynovitis presented with a decrease that was comparable to the decrease in the major composite scores. The authors said that ultrasound is also useful to evaluate change in time and activity of rheumatoid arthritis by combining a grayscale and Doppler score. And finally, looking for tenosynovitis in rheumatoid arthritis and in other inflammatory conditions is not only useful for diagnosis and for follow-up, but also useful for guiding injections and to make aspirations and inject pharmacological active treatments. Ultrasound allow to visualize the needle and to inject our pharmacological product exactly in the exact place that we wish to inject, avoiding placing the needle in at the inside of the tendon or extra tendon sheath. And this is not only more precise than performing normal injections, but also more effective. On the right, you have a study published 2 years ago, which compared the injection of glucocorticoids either locally on the inside of the tendon sheath or with the IV or IM injections. And you see that 12 weeks after, roughly half of patients that received local injections still had remission and are tenosynovitis free, whereas only 8% of people who received intramuscular and intravenous glucocorticoid injections still had were tenosynovitis free. So guiding injections allows more precision and more efficacy of our injection procedures. Unfortunately, until now, no recommendation of major rheumatology associations included tenosynovitis in the evaluation, in the standardized evaluation of rheumatoid arthritis patients. And so no single word is said about the importance of incorporating tenosynovitis as a standardized method in evaluating diagnosis, follow-up, and efficacy of treatments in rheumatoid arthritis. And this should change because, as we know, tenosynovitis is very frequent and very predictive, powerfully predictive of the evolution of a severe disease, and it is sensitive to change. So more efforts should be done in order to incorporate the follow-up and this systematic appreciation of the presence and importance of tenosynovitis, especially in rheumatoid arthritis patients, and not be only limited to the evaluation of joints only. So we have to be more extensive and more complete in our evaluation, studying as well synovitis as well as tenosynovitis that is very easily evaluated using ultrasound examination. So thank you very much for your attention and wish you a good Congress, and remaining at your disposal if you wish to have a kind of discussion or comments. Thank you very much.